Acute and chronic injuries are terms that are thrown about in sports injuries all the time. So it's over a period of time that some small injury that's been niggling at you, either at the hip or the ankle or the knee, you've known it's there, and yet you're still able to perform, not probably in your optimal and best performances, but still able to contribute to, say, team sports. An acute injury is a much more sudden event. So something like a sprain of an ankle or a knee injury that requires you to stop, and you can tell me the time, the date, and the exact nature of that injury. Whereas with chronic injuries, you're more likely to talk about something that's been niggling without an exact start date or an exact event that triggered it. One term that you may come across is acute on chronic, and this is where somebody has had a long-standing chronic injury with an acute event that has then pushed it over the edge to make it much more problematic for the patient. So whether you can tell them apart, the chronicity is absolutely to do with the timeline. So if a patient says to me, either I can't remember when this first started or how it started, or more commonly, how long it's been going on for, and they vaguely talk in terms of months or even years sometimes, then that's a chronic problem. If they say to me, this happened last week when I was on the football pitch or when I was skiing, then that's an acute problem. In terms of the symptoms, as you can imagine, an acute injury is likely to have swelling, severe pain, often sharp pain. The patient is often wearing a splint of some sort or a bandage. There may be even abrasions to the skin and associated other injuries to other parts of the body. In a chronic injury, it's much more likely that they're wearing some sort of strapping which they take on and off. And you can often, as a doctor, tell, or a surgeon, tell by the appearance of the strapping how long they've been using it for. And that's really a good it gives you a good ability to distinguish between the two types of injury. Well, so I specialize in hips and knees. I think within the knee, the most common acute injuries are something called a meniscal tear, which is when the soft tissue shock absorber inside the knee tears, and this tears because of an innocuous twisting injury. And then what we see particularly now as we come to the end of the skiing season and AstroTurf outdoor sports start to pick up is cruciate ligament injuries. So these are the ligaments that stabilize the knee. They lie within it, and particularly in skiing, because of the lever arm of a long ski, fairly innocuous twisting injuries can result in that ligament being ruptured. It is a drastic and life-changing injury when it happens, but we have the ability to treat it very effectively and get those patients back to the sports that they love, provided it's managed well and early. Within the hip, hip impingement is a common sports injury that has only in the last 15 years become far more recognized. And this often presents with groin pain that is exacerbated by either kicking or twisting. Patients feel it in the center of the groin and then radiating out towards the side, but it severely affects their ability to play sports or to run. And those are probably the two most common injuries that I see. Funnily enough, when you talk about chronic injuries to the knee and the hip, the actual pathology is the same as the acute injuries. So within the knee, it's often a meniscal tear or some degree of instability. And within the hip joint, it's impingement, femoroacetabular impingement. Where it differs from acute injuries is that patients have often rehabilitated and got back to a certain level of sport where they're able to compete despite having this chronic injury. A classic example is somebody who's ruptured their cruciate ligament, but then worked very hard with a physiotherapist to get their muscles quite strong. And you see this in downhill ski racers who are professionals. They have really strong quadriceps and muscle bulk around the knee to support the knee and compensate for the injured cruciate ligament. So 2 or 3 or 4 seasons down the line, as they start to wind down their levels of activity and the muscles become a bit weaker, you suddenly find that the knee's starting to give way in situations that it didn't previously. So that's kind of the chronic knee injury. It's the same with a meniscal tear. Patients have tolerated it. It plays up for 1 or 2 weeks in the year, but the rest of the time they're able to play competitive sport. and then they transition to a point where suddenly the pain is there all the time and they're unable to run. Similarly, with hip impingement, we see that chronicity is something, again, that they've learned how to adjust either the way they kick, or they cut down kicking with their left leg if that's the symptomatic side. But what we do see there in terms of the natural history, which is worrying for the surgeon, is that if it's left untreated, you can start to develop secondary problems from the acute injury by managing it in this way. And one of the common things I find myself saying to patients is the old adage of no pain, no gain is absolutely not true of joint injuries. It is a term that was coined when you're building up muscle, and the pain they talk about is that muscle burn in the gym that you get, where you have to get through that in order to get the muscle to grow and grow stronger. That is very distinct for when you have muscle tendon injuries, or particularly joint injuries, as I've just explained, where actually trying to run through them or go through the pain barrier is potentially going to do it more harm. So in those scenarios, I would absolutely advise you to see a specialist early and get good advice before you try and go for the no pain, no gain option. So with an acute injury, you're often at the pitch side. The first thing to say is recognize that if you don't stop playing, and often all of us are driven by adrenaline and a want to help our teams if it's a team sport, you're going to do more damage by trying to run through either an injured joint or an injured muscle. So stop. The first thing is to prevent the inflammation. So ice, elevation, rest, anti-inflammatory medication if you're able to tolerate it, and then some form of splint or brace can often help. And that's the acute phase of the injury. As soon as you've got that under control, contact somebody that you trust to get you to see a specialist. I think people often say, well, I didn't want to bother a specialist, and I saw a chiropractor, or I saw my physiotherapist, or I went to a minor injuries unit. All of these people are crucial in delivering treatment to patients. But particularly a minor injury unit is set up to just exclude certain types of injuries that probably require further hospital treatment. And once they've done that, they often pass the onus back onto the patient to see where they go. If you see a specialist, you're never wasting their time. And there is nothing embarrassing about a specialist saying, actually, you're very lucky. This is the kind of injury it is. You're not going to do much harm. This is the management plan. You don't require surgery. Working with a good physiotherapist, or in some cases a chiropractor, is going to make this better. And you've got that advice, and it gives you the confidence to then actively rehab. And there is a big difference between ignoring an injury and hoping that it will go away versus working actively to rehabilitate yourself, much as professional sportsmen do. Yeah, so I think it really depends on the severity of the injury and how much it's troubling you. I think I touched on it earlier in another question when I said, always go and see a specialist early. You will never miss the boat. If you're very early in the injury where it is still very swollen, painful, it could be that the specialist says to you, it's very difficult for me to assess this joint, because in the examination, it could cause you more discomfort and actually will not give me the ability to glean all the information that I need to assess the nature and extent of your injury. However, they still will be able to, if it's required, organize an appropriate scan that can give them a lot of that information. They will then call you back once that acute phase has settled down to then make a formal evaluation of the joint. We often assess the joints above to make sure that it isn't a secondary problem that has caused this, and the joint below, of course. So the simple answer to the question is see them early. See them early. If it's injured enough that you're worried about it, then these joints, if they're managed well, will get you exactly back to the levels of activity that you were enjoying before the injury. And that's what we want for all our patients, irrespective of age. You know, we've really seen a move away over the last 20 years of this concept that once you hit your mid-40s or mid-50s or even mid-60s, that you should be giving up some of the things that you enjoy. I think if you look after your joints well, you have a good specialist looking after you, they very much look to get you back to stuff. And even in cases of arthritis of hips and knees, I talk to my patients about getting back to skiing on the piste. getting back to 18 holes of golf, getting back to doubles tennis. So it may not be the intensity, but certainly the ability to get back and enjoy the sports and activities that you love is very much on the cards and part of my treatment agenda.